And if necessary, I can repeat the question here for those in the panel. So, please, any questions to the panel based on what we've heard so far this morning? Please. Yes.
Just a simple one to start. I was looking at the attendee lists and there's no GPs here. Are GPs going to engage with this?
Everybody get that question there? Yeah, okay. Good.
No, I didn't actually.
No. Right, I'll repeat the question when I stand up. So the question was, there are no GPs here today, and our GP is going to be able to engage in this. If they don't, we'll fail. Right? Absolutely simple. If you see, we've run a variety of models, health largely, but with some social work interaction over the years, from locality health partnerships to area committee type approaches. The ones that have worked best have had the GPs right there playing as critical partners. If you look at the Dumfries Hub experiment that we're running in Dumfries at the moment, where we've brought together some health and some social work teams, the big gap is that the GPs aren't similarly physically there at the time. If we don't find a way to make this really worthwhile to GPs in terms of giving them options of how they work with their patients that are better and different to the ones they have at the moment. So if they aren't enthusiastic partners in this, it will fail, because they are such a critical part of the universal service. So I am again hopeful. I think from a health point of view, we lost GP engagement as we centralised our management structures. And the centralisation of health management structures wasn't really any great master plan. It was because the Scottish Government told us to take 25% out of management costs. So every time someone retired, we didn't replace them. It was that crude and brutal. And we lost much more than we gained from that. So this ability to actually get back to a local structure, which makes much more sense to GPs, is, I think, one of the things I can be most enthusiastic about the whole integration agenda, in that we can start to play with them again as proper partners.
Okay. Gentleman here.
Sorry to disagree, I'm a retired GP. Mary's story could have been prevented if the GP had assessed that lady at the time. We destroyed all this with the giving up of 24-hour responsibility. I don't suppose that will be ever reintroduced, but we could go back to the local model of GP care that we had before the NHS 24 was imposed by Scottish Government.
Yeah.
That worked well in this area before then.
Yeah, that'd be really interesting, wouldn't it? I mean, obviously we can't negotiate the GP contract locally, but if you could start to look at those sort of local solutions to 24-hour, what happens when, that'd be fascinating. I'd be right alongside. I don't think we are disagreeing. I think we're basically talking about GPs suddenly finding themselves not part of key discussions about their patients, and we have to get them back into that key discussion about their patients.
The culture of GPs being responsible for the patients has gone now. Whether that can be rekindled, I don't know. There has been a huge change in culture, and this has actually demoralised GPs, and it's why they're spending all their time ticking boxes to earn income instead of really addressing their patient's problem.
Right, so I do disagree there. I don't think GPs feel less responsible for their patients. In my discussions with them, they feel frustrated by the mechanisms around them that are making them act in a particular way. So myself and the medical director meet groups of GPs periodically. The last one was just before Christmas, and just say, what are the things that are really annoying you at the moment that we can potentially fix? That box ticking for income is right up there, and there are things that we can do about that. So I think if we can get GPs actually seeing integration as giving them the chance to do more of the care, provide more of the care that they wish to, for their patients that they know better than anyone else, for the families that they know better than anyone else, I think we can address that feeling of the last 10 years has deprofessionalised them almost, you know. I think this is a way out. Again, I don't think nationally we'll get a solution to the way GP contracts work. But locally, and very locally, I think we can work around some of this stuff. The future on this bit may look better than the recent past. That's my big hope. As I said right from the start of the answer, if we don't crack this, if GPs still feel disengaged from the process, still feel that they are bureaucratic rather than the heart of an individual's care, this will all fail. We're wasting our time with this. Right? GPs have to be reintegrated into it. And my sense is they very much want to be, if we can give them the time and capacity.
Okay, yep. This lady here.
Can I just say something about GPs? It's not just about GPs, it's also about, we're talking about a holistic approach to people. Gavin wants his mummy to get something, in their community and whatever else, and that's great. But if you go into a hospital as an individual in Dumfries and Galloway, and you have certain different attributes that are going on in your health passport, you have different consultants, and your GP has got a major problem because nobody within that health authority is actually talking to each other. And I think that's it. That incident we were showing first was that there was no OTs that available that weekend for that lady. So some of her issues could have been, mobility and everything could have been utilised if there was OTs. So it's about how do we deploy people to work? How do we actually utilise the staff that we have? And how do we communicate? And I think that's what's happening within health. And then it's also the third sector and social work. So if we can't even get it within our own departments, we're going to have to work pretty hard.
Oh yeah, let's not underestimate.
I think GPs, you're right, there is bits about GPs, because if we're looking at step up, step down, so we're stopping people going in, we have to get GPs on board. We have to make sure that they're not charging, because there is bits a bit financial that we need to look at as well, and how we can actually get GPs to understand this is a holistic approach about their patients, how the hospitals have to understand that patients, people, and it's like people have been saying, we're not going to call them that anymore. No. What are we? Are we customers?
And this is I think this is a critical point, right, in terms of the scale of the challenge. And Gavin put it up, if we don't change, we will fail. In a sense, we are beginning to fail already in any number of interactions, and it will get worse if we don't address the scale of this. This is an enormous challenge. Right? Be under no illusions. There is no health and social care system in the world at the moment that can say we are fit for the future challenge. Right? It's like one of those. It's like climate change as a problem. It is every Western society is wrestling with this combination of demographic change, health technological change and specialisation, and constraint on budgets, and no one's cracked it. So the challenges here are absolutely enormous. You're absolutely right. And the way to fix them are to follow individual patients through the system. As that story, you could take sort of 15 learning points out of that 2-minute presentation. It was more, in a sense, it said more than all three chief executives standing up one after the other. You got more out of that story. Sorry, guys, and that I think fits very nicely with what we'll be talking about slightly later in terms of the person-centred approach. We have to gear our solutions around what actually happens to those individuals and their families and their carers as they go through our various organisations, and just repeatedly fix things and make sure we don't make the same mistake twice.
And I think that's right. If you're looking at collaboration and co-production, you have to be looking at the individual and building whatever it is around about them. And the only way we can do that is to have that dialogue. But it's
the other thing,
timeliest dialogue. I think what's happening is a lot of things are getting pushed at the last minute and people are still not unsure.
The other thing that you can get quite optimistic and enthusiastic about this is when you see a journey and a patient pathway that actually works really, really well. And we do it loads of times, absolutely fantastic. And, and I get letters that you can feel so proud of how the service reacted. It's actually, in resource terms, it's usually cheaper than when we mess it up like that. So you can get quite enthusiastic about, well, actually, if we can fix many more of our interactions to work as well as the best ones that we get right at the moment, then actually resources may not be the big problem that we're all worried about, because we'll be stopping wasting our time with repeat interventions, endless delays that cost money, keeping people in hospitals that don't need to be there. And you can start to get quite excited about how much resource you can reinvest into actually making things better, rather than the resource that you're spending to make things not work.
Yeah.
Okay, gentleman here.
Yeah, my question is a wee bit on a different tack here, and something which has not been mentioned, and some people in the room will obviously know what I'm asking about, and it's housing. We haven't mentioned housing. A person's home is their castle, and what part do the panel see the housing associations or social housing becoming part of this? Because in my view it is a very, very important part of the whole process, and without having the housing associations on board, it could lead to a bit of failure.
Let's be careful and answer this one. As you know, in Dumfries and Galloway, the council has no responsibility for housing and social housing anymore. Part of the strategic housing plan, but you're absolutely right, housing is essential to it. I mean, the government has got national minimum standards for housing. However, that doesn't apply to all housing, because if your house was built before the standards came in, it doesn't have to sit there. And there's huge issues around how do we deal with housing. Housing are at the table. Housing will very much be at the table. One of the things that we do not do well is having the housing ready to receive the individual when it comes back out. We have hideous bureaucratic processes that we used to have in place that, instead of making it quite simple, that as the old persons or the vulnerable persons in the hospital, send someone into the house to check whether or not the carpet's going to kill them when they walk back in the house. How do we enable that? But that's a local thing compared to a regional in the hospital. The other issue was who controls the money in relation to the aids and adaptations. The whole raft of issues around how do we make it simple for them just to get done? Because in relative terms, my budget is pennies. So these are the simplistic things and answers that we need to come out. But there's a second issue is, there's 4,000 people on the housing list just now. A number of them will be living in inadequate accommodation. A number of our elderly live in enormous houses, 4 or 5 bedroom houses, particularly in Wigtownshire, that they can't heat. So there's fuel poverty. So one of the things that we're doing together with Jeff and I and the council is an anti-poverty strategy, a total anti-poverty strategy that starts to deal with this on a holistic basis. Fuel poverty is only one part of the problem. So you're absolutely right, housing needs to sit there. But we need to do something about try to create some capacity to move people who will never be in a house fit for their condition. But to ensure new houses getting built are able to be lifetime houses. You've got to have bathrooms big enough to take a person for a wheelchair. If the person is tenure for life, they're going to end up there. I'm needing more room. We've already got that end done, but we're struggling at the front end because I said the 4,000 people eligible for housing but can't get it currently. So they have to be part of that. But what we're going to do, we promised to do, we're going to make it damn so easier for those frontline professionals. If that person needs a bar, needs some minor adaptations, needs something up to £2,000, just get it done. The money will be put aside. Part of our budget discussions is just putting aside a spot of money to just make it never a consequence for the frontline professional. If the person needs the aid, the adaptation, just get the contractor in, pick up the phone, they're on a contract. That's one of the first things that we will get to. And then develop the services like the handy van at the back to be able to deal with other things. Now that decision making is best done if the budget's not sitting competing against my school's budget in Dumfries. If it's actually down at the frontline professionals saying handy van or whatever the local organisation is the best place to do it. But housing's crucial, but I think it's a national problem. Virtually none of the housing built in the 60s, 70s, 80s and 90s was built with any idea the person would be in it when they got to 75. Because if you think about it, most of the housing was designed around Glasgow when you were going to be dead by 63. I mean, if you face it, that's where the strategic planning went. Nobody anticipated that you would need a bathroom to be able to cope with an elderly person to move around when the housing went up, even in the 80s. So we have to deal with that on a piece-by-piece basis. But I need to make it easier for the people at the front end here to actually say, that person needs £1,000 of work done in their house so I can get them back out of the house. That needs to be done in the 2, 3, 4 days that they're in the acute ward. Get in there, get it fixed, and don't worry about the budget. But it will be a hell of a challenge.
Can I just say, I attend housing conferences, and this is national, that as the gentleman from the third sector says, it seems like the third sector's tagged on at the end, it's just been brought in now. I think generally over Scotland, the housing associations feel the same. They feel it's a wee tag on. Yeah. But in my view, it's very essential that they're involved in the process.
Well, actually, if I'm having discussions with major housing associations just now about how we deal with limited number of families that are in their own homes. Exactly about that, about how we build that model. But because then you run against a legal claim of the homeless who have a right to be housed. So how do we together, working with Jeff, prioritise the health need over the homeless need, which the homeless trumps the health need? It does in legal terms. So therefore we need to work our way in the partnership around that to make sure it works to our priority. And then I've got 4,000 voters out there who are all demanding a home. So I think it's a complex issue, but it's absolutely critical. Nobody should live in substandard housing in Dumfries and Galloway. But some people do. A lot of people do. So that's why when you see the anti-poverty strategy, it links health, housing, income and jobs together. And I think for the first time, and all the housing associations are going to be buying into that, but it's absolutely crucial that we do. If you live in a substandard home, you're going to get ill. Full stop.
I mean, first of all, housing associations as industrial and providence societies are part of the third sector, very much part of the third sector. But within the third sector in Dumfries and Galloway, we are really not having a conversation across the different parts of our sector that include housing in that conversation. And one of the things that I'm intent on doing in the near future, Lorban Housing Association is a member of our organisation, the DGHPS, and all the specialist little housing associations are not either. And I think we need to bring ourselves together within our sector, those who are interested in the housing issues, not just the housing associations, but those third sector organisations that perhaps are fit for purpose to provide the aids and adaptations and get in there and be fleet of foot. But I want to make a political observation here. I'm a qualified town planner. That was my original career. I started out when I left school, wanted to be a town planner because I saw the importance of providing a physical environment for people to live in that allowed them to lead healthy lives. And it's interesting that we've had successive governments ignoring that particular driver behind planning and building control standards and have reduced the standards. It's not just that we were building houses in the 60s, 70s and 80s that didn't take account of people moving on to becoming older and staying in that same house. We reduced the standards to such an extent, and I don't know if anyone remembers this, maybe you do, Gavin, that Glasgow City Council put a shed in George Square and it complied with the then building standards that the then government introduced in the mid-1980s. So, that's the background to trying to get our housing fit for the people that are coming back into housing. So we mustn't lose sight of the fact that there's a lot of the point I'm trying to make, the political point I'm trying to make here is, the next time someone starts to attack housing standards, just remember that those housing standards were there for a purpose, and attacking them the way in which they were attacked in the 80s and early 90s, we're now paying the price of that, and we're going to pay the price of that for all the aids and adaptations that we're going to have to make.
Okay, lady here.
I've got a practical question. When I first came into social work, we had computer systems that was a joint working system that health and social care could input into. Now social work have created their own computer system, health have created theirs. We've now got no way of sharing information with each other. Is that something that's going to be addressed when health and social care integrate?
Mm-hmm. It's being addressed as we speak, yes. Right, what's the difficult public sector answer to that? We'll build a different computer system, or they'll use it, right, and they'll spend billions on it and they'll go nowhere. Dead simple. We actually went to a young person in the IT department and said, seeing this modern technology that I don't understand, could you possibly, what do we do here? They came back to Jeff and I, simple proposal. Actually, we can put a front end on that pulls all the information and permissions from the health system, all the information from the council system, and actually presents it to an individual. Now that I think we're going to be rolling out through this year. So you are actually, as a social worker, so if you're sitting with your health colleague, both of you look at a screen and all the information relevant to that individual will be in front of you. And because we're piloting it just now in the children's system, and it's going to be rolled out to the adult systems, absolutely. And what breakthrough was to not go, we'll go and buy another system. In social work, I see you smiling, that was a mistake in the first place. But actually, we just went to a frontline operative and said, what would, you're a really clever person, what would you do? And they came up with this wonderful answer, and they said, we can do it for £100,000, which is like a 50th of the cost of both systems that they're going to drag from. So that's the type of innovation we know can be there. Huge frustration. And actually, even though we have difficult children's service, some of the learning from it's been invaluable to take forward into the older people's services. And one was, we'd never agreed a proper information sharing protocol. And we sorted that within, I think it took a week, 5 working days for us to agree it and come with this idea. So it can be done if you don't leave it, if you forgive me, to us to think about it, because actually, people like yourself know the answers. We just need to enable you to have a team to talk to make it happen. But you will have before this is rolled out, a single system will tell you everything you need to know about your own. Within your allowed limit, because obviously there's some clinical stuff you wouldn't get to see, there's some social work stuff that can be shared. But you'll determine what that is, and you'll have that system, and that again.
If there's any intention to focus more on prevention in terms of screening for different illnesses at an earlier stage, and I believe you can test for pre-diabetes before people actually become proper diabetic. Most of us don't actually think about treating their health until we're diagnosed. But if we were all aware about what we were heading towards, it might make us a little bit more conscious.
Okay.
I think health improvement teams working around the communities in terms of that healthy lifestyle choices, etc., are going to be a critical part of this. We have to somehow change the future from Gavin's graph. We have to try and stop that increasing age of a population turning into increasing morbidity. We have to change the relationship between age and illness. Again, there are no real magic bullets on this. Screenings that are becoming increasingly prevalent for a whole range of, and you mentioned it, I think, pre-diabetic. In a sense, what the hell does that mean? Everyone's pre-diabetic who isn't diabetic, I guess. You can get companies and technologists that wish to sell us products around health screening that actually take us in completely the wrong direction, where we over-medicalise whole swathes of the population that don't need medical intervention at all, just to get this 1 in 100 that it makes a difference for. So we've got to go into this with eyes wide open, but I think the embedding of health improvement teams into these locality structures, into these community teams, will be really powerful in saying, look, let's talk about lifestyle choices, let's talk about how we work on quite a small scale to give communities and families within that community the opportunity to exercise healthy choices. I think the era of us putting lots of resources into things like stopping smoking campaigns, etc. I think that era is probably coming to an end. I think we're much more about trying to talk to families and communities about what healthy living looks like to them, and what are the barriers to them moving down that path towards healthy lifestyle, other than saying, right, you're a smoker, therefore smoking's your problem, therefore we'll try and help you stop smoking, when actually smoking is more symptomatic of general, more lifestyle type issues and life experiences. So I think, again, as we get more local in our problem solving, we can get to some quite interesting places there. Screening clearly has its place, and I wouldn't want to dismiss screening particularly, but we just need to be careful as we're getting more and more technologies opened up to us, that we don't see the future as increased medicalisation. We actually work with families and communities to stay healthy on their own terms.
Yeah, but I think if you have a proper prevention plan for that, we need to include things like how to identify early stages of things. For instance, people that get COPD can be picked up before they're actually at a stage of needing treatment for it. So it's just a bit...
But it's not what the point I'm making. I'm not dismissing screening. The point I'm making is that many of these are not medical issues in isolation, right? And if you look at healthy eating initiatives and healthy weight for children initiatives that we've been involved in for years and years, when our teams are going into houses and working with families, they are finding families who don't have cooking utensils, right? Who don't know how to cook meals. And how can we go in and preach to them about healthy weight of children, right? We need to start at a different place altogether about what does healthy living look like for you and your family. And I think we need to make sure that we're not just going down that straight medical line of let's find your condition, let's give you a treatment or a pre-treatment for that condition, but actually talk to families and communities about what does a healthy life experience look like to you, and what are the barriers to you for getting to those, and let's see if we can fix some of those barriers. And that's the slightly more holistic one. Well, the high-tech medical thing clearly has a role, but it mustn't be our default position. Our default must be that let's try and empower people and families and communities to live healthy lives.
But does that not bring education
Yeah,
into
very
the
much.
fore early?
It makes it a much
Yeah,
more difficult question, unfortunately. Almost the easy answer is to say, right, I'll stop you smoking, I'll give you this this drug, and that will lower your chances of progression on
I was
diabetes.
thinking about schools, going back to bringing the old days, the domestic science, all the different things that gave you healthy eating. That seems to be lost.
I think you can make the question as big as you like, because in some senses this is a question of poverty.
Yeah.
We don't go into wealthy households and find no cooking utensils and no ambition to cook meals. So this is a whole community resilience and a health inequalities and a wealth inequalities question. You can make it as big as that. And I think we've got to keep our eyes on those big questions always, and not get driven into focus on the very narrow medicalised answers. I don't think that's what the future looks like. I'm very conscious we've got people with much greater expertise than me in the audience when I'm talking about this. So just shoot me down if I can. How do we work with the individual around the right choices for them? And I think this, again, hopefully we will touch on this in the later session, this real core problem of, for so long we have been focused as professionals, as statutory agencies, on what can we do for you, individual. Right? And as medical technologies change, that list from a health point of view gets longer and longer. What we can do for you gets longer and longer in the options. We are going to have to change that into a what's the right thing to do with you? What actually gives you the best outcomes and the things that are important to you as an individual? And for an individual, I don't think necessarily that is a discussion about how we reassure an individual that hospital's the right place. I think it is a dialogue and a question of, is hospital the right place for you? Or is there another set of interventions that actually we can look for? Some of the political debate on this is almost misleading, frankly. It's almost deliberately misleading. We talk about treatments and care pathways and cures and new drugs as though people aren't going to die. Right? People are going to die. And some of our discussions with frail individuals with multiple comorbidities, issues, should not be about what can we do for you here. Here's the list of things. It should be about what's important to you in the time that you have left, and how do we make the end of your life a positive and dignified experience, rather than carting you off to a hospital where there are lots of things that we can do for you and lots of heroic interventions that we can make, but may not actually be what you or your family would want. And that's profoundly difficult. You will not hear politicians standing up and making great speeches about this because it scares the hell out of them. But us, right, with the responsibility to our communities, to our families, need to start thinking along those lines as well. That this is not always about, here's the long list, and we need to persuade you that everything will be all right if you come into us and we'll do these interventions. We're talking in the future much more about a dialogue with those individuals and families.
Okay, sorry, time for one more question, because we're well over time, but we can manage it. Lady here, one last question, folks. Sorry.
Can I ask what's going to be available in the out hours, in the sense of, like, a lot of these things crop up and they arrive into A&E on a Saturday or a Sunday or a public holiday, and they end up getting admitted and becoming the bed blocker, if you like, when all that they need is like either a social work review or an increase in the service or something, will this be available in the out hours?
Right. Actually, our most successful work stream at the moment is our OD one, organisational development. And why? Because we've actually got the tools now to do annualised hours. Where's the biggest pressure in the system? I'll look across the college, it's winter. Particularly probably November, December, January, February. Many of the young people coming into the system now would love to do 8 months and 4 months in the summer disappearing like they do in Australia. We've got 5 over 7 working, so basically you could do 5 days over 7 days. Some of the barriers were structural in GP contracts, consulting contracts, the way that we run the council, the way the third sector's set up. What we're saying is that the OD's coming up, this needs to change. But if we could look only to our answer, we really start to struggle. Like the physiotherapy answer, why does it have to be an NHS physiotherapist? I don't want to get into terms and conditions, union issues. But actually in your local area, it could be a call of a private person who wants to set up in Wangham or Newless. A young newly qualified, we draw their services, they could do other work, they're there. But absolutely, this needs to be a 24/7 service.
A lot of patients, they don't want
and
to.
And part of the problem we've got with that lady was, did it need to be a GP? Did it need to be a consultant that said she wasn't dying? There's a risk, consultant risk there, there'd have to be an E. What could we have put in place that had prevented us, take us slightly minor, to going into that place? What resources? And the teams need to tell us that. Because when we look at it structurally, you end up having, I'll have 5 consultants there, I'll have 4 social workers there, I'll have 2 senior office managers there. Actually, that's simplistic how we can work it, that's the way we do it. Actually, at the local level, you might need a different mix. And what the Dumfries experiment, the hub's doing, is showing we can't step it down on a Friday afternoon, because if the GP's got nobody to talk to at 3:30 on a Friday, where will they put the vulnerable person? Quite rightly, into the hospital. And that hospital, you know, for most of our patients will be quite a distance from their home in Dumfries or not. But they'll bypass qualified nursing homes with nurses. They'll bypass other facilities to get there. So we need to deal with it. That's why I think we get that planning right. We can start to do. There are terms and conditions issues we will have to work our way through. But the enabling power of the Act means we can start those conversations and we can work it out. But this idea that we're still structured around 9 to 5 when the technology and our need, and actually most old people tend not to fall down between Monday and Thursday. So therefore, but it's not just that. The other bit we're not talking, we don't talk about older adults. We have wonderfully the ability to keep our seriously ill children living longer. They're now becoming seriously ill, dependent adults. That's fantastic. That is absolutely what we should be about. We're not geared up to deal with that. So this is about all are vulnerable. The model we're putting is about all are vulnerable. How do we deal with that issue? Most of the people I've now got at 20 would have been dead in their teens or early ages. That's wonderful for their families, it's wonderful for society. But we're not structured to be able to provide that kind of locality. And we start to look out with region for these issues. That's wrong. So that's included in this. When Jeff and I are talking here about elderly people, we're actually talking about all are vulnerable. How do we put up that level of care? And a lot of those answers lie with an empowered third sector to provide some of those interventions. And how do we deal with them to keep and deal with it in locality? That's where localities sit. I'll give you a simple example, just to make you laugh. When I first started here, I got this phone call. There was a brilliant case in Langham. It's a bit apocryphal, but you'll resonate with this. An old woman had fallen over, fallen out of bed. Who did she call in Langham? It wasn't 999. She called the policeman, because they'd always called the policeman in Langham. What did the system do? The system sent an ambulance, alerted the on-call GP, the on-call social worker. I think there were two other low third sector agencies. In the end, 7 people turned up, and all she wanted was back in bed. Why? Because that's the way the system was set up. So that's not the way it works. But actually, everybody knew that woman, but we still have the response of the system was to put 7 interventions. And that's what, if we can break that, we can recycle the money. It won't answer all the problems, but we can deal with it. But getting that 24/7 as reasonable as possible. Now that might need some pub priming investment. Jeff and I are committed. We are prepared that this will need some pub priming through the first couple of years, and we have been putting money aside to help pub prime it for these good ideas. but one of them's got to be what happens when a GP is faced with an older person at 3:30, 4 o'clock on a Friday. And if we can crack that locally, that will start to the answer, and the answer invariably will not be send them to Dumfries.
Okay, David, you want to just...
Yeah, I want to pick up on the sector at that point. Your voice, and I can't see you because you're in the dark up there. One of the important things we need to do, Gavin, I think, and Jeff, is to listen to voices of the third sector. But one of the things that third sector organisations are well placed for is to listen to the voices of the user. And they're sometimes, and I'm sorry if you think this is an insult, but they're often better placed because they probably get more contact with that individual than the state organisations and the NHS and the council. So my hope here, Gavin, is that as we move to this system that you've been designing, that your voice will be heard, and you in turn will be voicing the concerns of the person that you're dealing with, and that out of that we'll be able to design solutions in that community. You know, and it does strike me, we've had this conversation before, and it's a pity you mentioned Lyme, but it does strike me that, you know, there are communities like Lyme that are remote. You can't, for example, get a bus from Lyme to Dumfries. I'm not sure you will know that, but you know, there's no direct bus that goes from Lyme to Dumfries. So the consequence of that actually is that they're quite tight-knit communities. How do you take that tight-knit community and enable them to respond to that case you just in a sensible way, and a way that isn't heavy on resources? Now, I think if you empower communities and you empower the third sector to be part of that discussion, we may well make progress.
Okay, thank you. Right.